All right, I want to talk to you all briefly about hemodynamic monitoring in our perfusion section here. For hemodynamic monitoring, really what we're talking about is we are assessing the circulatory system a little bit more globally than we could if we were just, checking a blood pressure and a map, and then some of our signs of peripheral circulation like skin temperature and color and things like that. So we're actually getting some pressure readings that tell us about the circulatory system as a whole, and specifically the central part of the circulatory system between the heart and the lungs. So of course we remember that people need to maintain perfusion of vital organs to maintain life. That's really our main focus and concern. So if we think about perfusion, that's essentially just the circulation of blood through tissues for the purpose of delivering oxygen, right, and other necessary biochemicals for cellular function. So we have to maintain that oxygen-rich, nutrient-rich blood being circulated through and perfusing, especially the vital organs. So remember that your body tissues are perfused by capillaries, which are those little small vessels. So think about what happens when you, partially kink a garden hose, right? You've made that opening more narrow. So because you've made that opening narrow, it becomes a higher pressure system. So capillaries, likewise, have a very, very small lumen or opening in the middle. So they're like the kink in the hose. So this is true in two kind of important ways. So there's a capillary bed in the lungs, which you can see here on this picture. That's a higher pressure system. There's also a capillary bed that's present systemically in all of your vital organs. Right? So you have two high pressure areas there. So we have to maintain a certain amount of pressure on the supply side or the pump side of the hose to keep the water flowing to the downstream opening. So we have to maintain a certain amount of pressure from the left ventricle to continue to perfuse the vital organs systemically. We have to maintain a certain amount of pressure from the right ventricle to perfuse the pulmonary circulation appropriately. And likewise, we can't have too much pressure backing up on the opposite side of either system. So we can't have too much pressure on the pulmonary vein side of the pulmonary system because then it backs up and creates too much of a workload on the right side of the heart. And the same thing is true in the systemic circulation. If we have too much pressure, back pressure, on the left ventricle, it creates a heart failure situation where that pump is not able to exert enough force to actually circulate the blood through appropriately. So there are really two things that control the pressure in the hose. Remember, it's the flow or the volume and also the size of the opening of those various tubes or systems, right? So you can adjust the flow, which essentially when we're thinking circulation, we're adjusting cardiac output, and we think mostly of cardiac output in terms of the left ventricle because that is what's perfusing those vital organs systemically. There's also the size of the lumen, so vascular resistance, so how large or small the arteries or capillary systems are. So the smaller it is, the greater you increase that pressure, which is what we want to do sometimes if the supply side is really low. So if we have low volume, you have arterial constriction, which increases the pressure. But if you have a normal volume and you constrict that lumen, it creates too much pressure on the system, and then we have downstream and upstream effects either direction. Right? So both things are important. So there's also the force of contraction, which essentially is the pump. So when you think about the heart, how hard is that, how much force is that pump creating in the system also affects the pressure. So we want to monitor really all of these things, especially if we have a really critical patient that might be at risk for right-sided and or left-sided heart failure and or pulmonary edema or perfusion to their vital organs. So when we do hemodynamic monitoring, essentially we're measuring pressure, we're measuring flow, and oxygenation of the cardiovascular system. So some important things that we would measure would be cardiac output, so how much blood is being pumped every cycle per minute, essentially, is how we measure that. We have cardiac index. So when we do a cardiac index, it's essentially the cardiac output, but it's adjusted for body surface area. So the size of the person, the body, matters as far as what's a good or bad cardiac output, right? So we can adjust for that by calculating the cardiac index. We also have stroke volume, which is the volume of blood pumped with each heartbeat. So cardiac output is the volume of blood in 1 minute. Stroke volume is the volume of blood with each heartbeat. And you can actually calculate what's called a stroke index, which is also adjusted for body surface area. And then the other basic measure that we would think about would be our MAP, or mean arterial pressure, which is measuring the average between the systolic and diastolic pressures. And anything less than 70, we get concerned that the vital organs are not being adequately perfused, right? We're having a lack of blood flow. And so then we start to risk neurological damage, we start to risk multi-system organ failure, and things like that. All right, so let's jump into a little bit more detail. So we can put in a central catheter, pulmonary catheter, otherwise known as a Swan-Ganz catheter, which we'll talk more about in a second. They can give us a lot of different pressure readings. So the first of those is we can do this with a blood pressure, or we can also do this with an arterial line. So an arterial line can go through the radial artery, and it can continually measure blood pressure, and we can also calculate, of course, a MAP, right? So that mean arterial pressure is important to us because, remember, that's the average pressure in the arterial system. So below 70, we start to worry about organ perfusion. We also have central venous pressure, which is essentially a measure of right ventricular preload, okay? So how much is sort of ahead of the right ventricle pumping, how much volume. So an elevated central venous pressure is going to tell us that we probably have a right ventricular heart failure or fluid overload. A low CVP is going to tell us that we have hypovolemia. All right, and then next would be pulmonary artery pressure. So it's measuring essentially a blood pressure, but inside of the pulmonary circulation. So when you measure blood pressure with your cuff, you're measuring systemic circulation, right? So that's measuring a lot of the left side of the heart values, right? Well, the pulmonary circulation is perfused, of course, by the right ventricle, the right side of the heart. So we can do the same thing with this catheter. We can actually measure the pressure inside of that pulmonary circulation. And we're really mostly concerned about the systolic pressure. We'll talk maybe later in some cases about the diastolic pressure too, but right now we're most concerned about the systolic pulmonary artery pressure, which ranges between 8 and 20. So a high pulmonary artery pressure is going to indicate probably that we've got pulmonary hypertension, right? So pulmonary hypertension, we're not going to discuss all the details about that, but there's some downstream effects to that as well, right? Developing right-sided heart failure, etc. Okay? We also have this thing called a pulmonary capillary wedge pressure, sometimes just called a wedge. Normal low is 6, high is 12. So this is essentially, we'd say, an indirect measure of left arterial pressure. So it would be elevated. If it's elevated, it's telling us you have left-sided heart failure, or you might have some kind of mitral or aortic valve failure. So anything greater than 20 in your wedge pressure, anything over 20, very likely that you're going to have some pulmonary edema occur because the pressure is so high that it makes those capillaries leaky into across that pulmonary alveolar membrane, right? Capillary alveolar membrane. So you're going to have some pulmonary edema develop. All right. The systemic vascular resistance essentially is kind of like measuring a blood pressure. So systemic vasculature is anything after the left side of the heart, right? So including the aorta all the way down to your capillary beds in your tissues. So SVR ranges from 900 to 1200. Essentially, if you have an elevated SVR, you are probably also going to see an elevated blood pressure as well. But that helps us understand how much workload, that's the afterload, present on the left side of the heart. So how much force is pushing back on the left ventricle as it's trying to push blood forward. So how much workload is the left side of the heart having to exert in order to continue circulation in the systemic vasculature. All right, so the next one would be PVR, or pulmonary vascular resistance. So same kind of idea. It's telling you how clamped down or how much pressure there is in the pulmonary vasculature. So how much, that's an afterload, a right ventricular afterload measurement. So how much force is the right ventricle having to exert against the force that's present, the pressure that's present in the pulmonary vasculature. So the next, of course, we talked a little bit about cardiac output. So anywhere between 4 and 8 liters per minute is acceptable. So that's how much blood, the volume that's being pumped out per minute by the left ventricle. And then, of course, we correct that, as I said, with a cardiac index, which can range from 2.5 to 4.5 liters per minute per meter squared. So again, corrected for the patient's body surface area. That gives us a more accurate picture of what the left ventricle is actually doing in regard to perfusion. And this is essentially taken from table 65.1 in your book. So you can reference that again, or you can reference this PowerPoint for these normal values. Be useful for you in the next section of content here. All right, so let's talk a little bit about an arterial line. So as I said, an arterial line is usually inserted in the radial artery, though it can be in the femoral artery as well. That's the other kind of common-ish place we will put it. But we prefer the radial artery simply because there's less risk of infection, it's easier to access, it's easier to zero and manage and sort of handle. Okay, so with an arterial line, you have some important components. So because it's an arterial line, not a venous line, it is a much higher pressure system. So that catheter has some pressure against it. If you don't have a pressure bag, which essentially is a bag of saline with like a blood pressure cuff around it, that's squeezing that bag at a certain pressure to counter the pressure that's in the artery so you don't get backflow into your line, right? So you have a pressure bag and your flush solution, which is generally just normal saline. Then down the line you have a 3-way stopcock and a transducer. And then what's called a flush device. So it's essentially a valve. You can just pull that open and it lets that flush solution flow through uninhibited. And then you have some thicker tubing. It's pressure tubing, so it's kind of heavier. And then there is a port usually further down that you can use for specimen collection. And then there's a cable, of course, that runs from the transducer, which is like the sensor, the pressure sensor, into your monitor. So this will allow you to measure a continuous blood pressure and also calculate a map. And you can actually have it calculate your map automatically and keep track of that. All right, so one important thing about an arterial line is you have to zero it, which means that the transducer has to be at the level of what's called the phlebistostatic axis. Yes, very exciting. Which is at the 4th intercostal space, the anterior chest. So outermost posterior chest, 4th intercostal space. You should be very careful to figure out exactly where that is on your patient, because if you don't have your arterial line properly zeroed and leveled with that phlebistostatic axis, your readings on your line are not going to be accurate. So yes, this means every time, or relatively, every time your patient moves in bed, you roll them to change their linens, to do pericare, whatever, you technically need to re-level your arterial line transducer and zero it out again, just to make sure that your readings remain accurate. If you don't do that, then you risk not being able to pick up on more subtle signs of hemodynamic changes. All right, so you can get a specialized sensor, and it depends on your where you're working, I'd say most places probably have this, that can actually do some extra calculations, and they can calculate a cardiac output and cardiac index based on the data that's being fed into there as well. So you would flush this every 1 to 4 hours, keeping your pressure bag somewhere in the neighborhood of 300 millimeters per mercury at all times, so that you don't get backflow into your catheter. All right, and tubing. So the next thing I'm going to have you do is watch a video that instructs you on how to properly level and zero your arterial line. So once you've watched this video, now you should have a pretty clear idea of what it is that you're looking for with an arterial line. So the next little piece I want to talk about is called a pulmonary artery catheter, otherwise known as a Swan-Ganz catheter. You'll probably hear it called a Swan most of the time. That's the original inventors of this particular catheter. So as you can see in the photo, we usually insert it into subclavian vein. It can be right or left side. We feed that through the vein, through the superior vena cava, and into the right atria, all the way through, and then into the right ventricle as well. All right, and then what we try to do is get that to float up into the pulmonary artery. Right, so we're feeding this catheter a fair distance. It sits in there in the pulmonary artery, and we can get most of our hemodynamic monitoring values from these catheters. So this is pretty interesting. As you're floating the catheter, you're not doing it as the nurse, the physician is putting this in, right? But as they're floating the catheter, you can actually see changes in the pressure reading on the transducer. So if you see it in the right atrium, it's going to look a little bit like this first section. And then once it gets into the right ventricle, clearly a higher pressure area, you're going to see a much larger waveform, right? Different variations. You can see the bottom of that waveform represents the diastolic measure, give or take, and then the top represents the systolic pressure inside of the right ventricle, which I always think is really pretty crazy and kind of cool. And then for the most part, most of the time when you're monitoring this, you're going to get your pulmonary artery reading on the transducer. So it's going to look like this third section of this diagram most of the time. At times you'll be asked every so often to measure what's called a pulmonary artery wedge pressure, which we talked about earlier. And when you do that, you inflate the balloon at the end of this catheter, like it shows in this diagram, and you actually occlude that pulmonary artery for a minute, very little time actually, and you will get a waveform that looks a little bit like this. And so you'll get what's called a wedge pressure reading there, and so that's how you get that particular value. Also, these catheters can measure oxygen saturation moving through the venous system. They can measure a CVP. You can measure cardiac output, usually by what's called a thermodilution technique. There's a temperature sensor on the end of this catheter, and so you inject cold saline into one of the ports, and then it calculates how fast that cold saline moves past, basically past that temperature sensor, and you can calculate a cardiac output and then of course a cardiac index if you know your patient's body surface area. You can also do temperature monitoring centrally with this catheter as well. All right, so a Swan is useful. We can calculate a wedge pressure, pulmonary artery pressure. You can calculate cardiac output, cardiac index, systemic vascular resistance, and pulmonary vascular resistance, all with this particular catheter. All right, so the last little piece here I want to show you is a video basically just describing the Swan and what it does, kind of how it works, giving you more of a close-up view. So hopefully you find that helpful. And of course, we'll apply this hemodynamic monitoring and these numbers. We'll talk more about that when we do some cases about what these things might actually mean. And of course, you'll get some of that as you're doing your reading. So watch this video, and that'll be it. Thanks for listening.